Yes, now for something completely different. And for those who like money, the NIH, we give money. So we're going to give you a 5,000-foot view. And Wendy and I both come from the Office of the Director at the NIH. NIH is a big place, 27 institutes and center. And so we're going to give you sort of the broad overview. Tomorrow you'll hear from Dr. Pettigrew from the National Institutes of Biomedical Engineering, Imaging, and Bioengineering, who will give you a sort of an institute-specific perspective. But we're going to give you the 5,000-foot perspective. And so for those who rely on grant funding, this is what you sometimes face. You know, I was close to a breakthrough when the grant money ran out. So for those who rely on grant money, I know you kind of understand this cartoon, and we're from the government, and we're here to help. So why forward? So why is it important for NIH? And I don't need to tell this audience that we are living in a digital age, and the internet, cyber infrastructure is all over the place. But we're also looking at a wireless mobile revolution, and it's all over the media, consumer-based applications, sensors, and mobile phones. They're everywhere. And so we at the NIH, we recognize this, and we also recognize that there's a proliferation of mobile apps, as exemplified by just sheerly the number of iTunes apps that currently exist. And the number of users of mobile phones, specifically 83% of the population in the US have mobile phones, with cell phones, you know, just dominating, smartphones, feature phones. And when you look, this graph is hard to read, but when you look at the users, and you look at health disparities, the people who use mobile phones, the African Americans, Latinos, are more likely than the traditional, the white populations to use mobile phones. So it opens up a nice opportunity. But you also open up a gap with older adults in this generation, which 57% are less likely to use mobile phones than others. And so there's some trade-offs with using the mobile technology. For NIH, it's not about the technology, though. For us, it's about enabling health. And for us, it's about asking, what is the problem to be solved? And as some of our other federal partners says, you know, what is the requirements that you are trying to meet? What is the hypothesis that you are trying to solve? That's what we're looking at. It's not about the technology and the technology development. It's how to use the technology to enable improvements in public health. And so my colleague, Wendy Nilsen, will talk about the NIH activities in mobile health.
Thank you, Audie. I think that the point to remember here is we don't need a wireless hammer looking for nails. And in NIH, that's not what we're going to fund. We have a lot of health problems in this country. There's many, many things that wireless can help. So I want you to start to think about that. Well, you're all thinking about that now. And now I can't make, okay. As we pointed out before, NIH is a very, very diverse place. There's 27 institutes and centers. We're in the Office of the Director, which is a fabulous place to be because we get to see it all. But you will be working with these different institutes and centers. Remember, each one has a mission. Even though NIH's mission is for to improve health, each one has a special focus. So you need to think about that as you're applying for money. We've done some preliminary analysis looking at how does wireless work in NIH funding? How does it come out? And it's very difficult because this is obviously a new area. I mean, you've pointed out, many people have pointed out, it's been around a while, but really, gathering speed now. And so we don't have an easy way to record what it is. But this is just an example of grants funded in 2009 that were with the word cell phones, cellular phones, mobile phones, and smartphones. And you can see it's spread throughout our institutes. Some are more interested in others, but I think that might be relative size too. I mean, the interest is there. People are excited by this. We wouldn't be here if it wasn't, so. We also, just to show you the level of interest, NIH is a meeting-heavy place. We do meetings and meetings and meetings. We don't need any more. But Audie is actually leading an mHealth interest group at NIH. And if you look at here, 18 of our 27 institutes and centers are represented with a standing member to this interest group. So sometimes we have more than that. So this is how intense the interest is now. These are some examples of activities. These are not exhaustive at all. I mean, this is happening on a daily basis. Many of you will get invited to NIH to talk about this. One of the reasons I love to come to these conferences is to see the new exciting research, and then we can talk about that when we get back. But there's many activities throughout the institutes. We do a lot of training. We do a lot of meetings around. We held a barrier in my office in OBSSR, looking at the barriers to mobile health in the behavioral and social sciences. Many of those barriers are what we've talked about in this session. But there's many, many things that have been happening. So how do you get money from us? I mean, that's the $64,000 question. Everybody talks about it. We have multiple methods for getting money. We have requests for applications. These are coming out, and they're very targeted. They'll be specific. People get excited because there is money set aside for that. So the Institute has said, I'm going to put $10 million toward this. So it generates a lot of interest. People often think, oh, this is a better bet. I will say that often when we put those out, we get a lot of applications too. So think about that. The other thing are program announcements. There may not be money put up front for these, but if there's a program announcement, there's interest. And remember, the important thing at NIH is 80% of the grants are investigator initiated. It's your brilliant ideas that we're looking for. We don't think we know it all, or why would we be there? Right? We're looking for you to tell us what's the latest, hottest, coolest thing that's going to change the country's health. Our grant mechanisms, we have many. There's some websites in here that'll really give you links to them, but we have from small grants where you're piloting projects and you're thinking about it in R03, small research grants. We have the R01s. People say, oh, that's great. It's big, it's a lot more money. Remember, the grant has to match the question and the problem. Don't think, I just want a lot of money. It's not going to work in a study section. So, and the other thing to remember, too, is we have small business innovation grants, the SBIRs, and we have an STTR. Many of you would be well suited to be looking at these. The NIH has set aside amounts of money that are put toward this, and we're looking for really cool innovations. Here's our important websites. The Office of Extramural Research has any question you've ever asked or never even thought to ask, it's there. The Center for Scientific Review has a new video on how to apply for funding, a simulated study section, very cool. And then the reporter database. Don't think that you are the only person who's ever thought of this. Look. The reporter database has every grant funded reasonably, with, especially in the last 10 years. But it'll tell you, if you look in there and you think, I'm the only one that's ever thought of a body sensor network. Well, you can find out how many actually were funded. What's the common mechanism? How do they do it? Which institutes are funding it and what? Because you can read their abstract. So you can get a lot of information about what's out there, who's interested in what. Okay. So just let me quickly talk about some of the challenges, because I think our colleagues have really talked about this. NIH has a slow funding mechanism, and we hear this all the time in a technological world where things are changing so rapidly. And in NIH, it takes a long time to get money. So you have to think out kind of in front. I think Audie always says, like, you have to skate in front of, skate to the puck. Think about that as you're applying. It's a long time, but we do provide quite a bit of money. You need these interdisciplinary research teams. This end-to-end research, we want to see it. We want to have that. We think about the research methodology for data collection analysis. We really value that science. It's so great to be here to see the science. Often we hear all the wonderful things that wireless health will do with no data. That's not what NIH gets excited about. I will say that people consistently say, oh, but study sections, they won't fund this. They won't like this. Study section is made up of you. Program officers don't sit at study section. If there's conservatism, if there's hesitation in wireless health, it's from your peers. So go out there and be a study section reviewer. You can change, if you want to see this research funded, then go and do your civic duty as an academic and sit on sections. And then, we have the IRB, HIPAA, and working with carriers if you're doing that.
So I'm going to bring it home talking about partnerships. Because as Wendy mentioned, there's a disconnect between the technology development, which is fairly fast, and the NIH funding process. And so, we hear that all the time there's a data tsunami, and there's a data tsunami for the reasons why you guys are here. I mean, I'm really impressed by all the cool technology, the cool tools, the sensors, the body area networks, accelerometers, all linking up to cell phones, Bluetooth, Zigbee. But all this data is proliferating the amount of information that's stored, as well as it's advancing at a great rate. And so we're trying to figure out what are ways that we as NIH could work to meet funding opportunities in the time that technology develops. And so there's this office that I work in now called the Public-Private Partnership Program. And this office was formed in 2005 to do exactly that, to do public-private partnerships with industry and others to accelerate the pace of research. It is trans-NIH, and it is part of the government. So we abide by the rules and regulations of the federal government. We realize that we cannot, as NIH, do it alone. We are a big organization with lots of money, $32 billion annual appropriations, but even with that, we know that we cannot do this alone. And so we know that we need to partner with industry, other nonprofits, with organizations to create synergy and opportunities. It may be no surprise to you that, or maybe you're surprised to you, but NIH, we're like moving a tanker. We're not a swift canoe. We move quite slowly. And so we need to partner with others who can move quickly in order to move this field forward and to accomplish our mission better, faster, and more efficiently. And so we are looking for the sweet spots. So we partner with other federal partners, with the public, with industry, to meet common goals. And that pink area is partnering for public health. That is our primary mission, to improve public health. And so to the effect that we can do that with other partners, that's the spot that we are looking for. And this slide to show that we partner with both government and non-government agencies. It's easier for us to partner in many respects with government agencies because we can do an interagency agreement, transfer money pretty quickly. But we also look to foundations like the Foundation for NIH, academic institutions such as the ones you belong to as well, and professional societies, companies to form collaborations in different areas. Who will we partner with? Pretty much anyone. We're fairly promiscuous. I mean, government don't really match with promiscuous, but unless you're in the Clinton area. But we have to do. It has to be science-driven. It has to be rigorous, fair, inclusive, and transparent. But even if it's all those things, we still may not partner because it has to meet the priority of the agencies. So sometimes we may say no. Even if all the ducks are aligned, we may say no. Some of the partnerships are federally managed. We get gifts from different organizations that are, we disperse them as grants through the NIH process. But we also form partnerships that are outside of NIH. And I'll give you some examples in a little bit. But in each partnership is distinct. And we are currently developing partnerships in mobile and wireless technology that I'm not at liberty to announce right now, but we'll be able to announce soon. Beware that when we do form partnerships, we are bound by federal regulations, the Bayh-Dole Act. We cannot delegate federal authority. We cannot say, okay, you guys make the decisions about how federal money is spent. We cannot do that. It's against the law. And then we have certain restrictions about who we receive advice, quote-unquote advice from, and how many people we're allowed to receive advice from. And we have to abide by the policies with respect to grants and contracts of how that money is allocated. So these are examples of partnerships that have developed at NIH, and these are not specific to mobile health, but these are some clear examples, and there's some websites out there, how NIH has partnered with foundations, with pharma, with other federal organizations to look at biomarkers, Alzheimer's disease, genetics, as well as look at asthma. And so there are opportunities that we are actively engaging in now with respect to mobile and wireless health to move the field forward. So with that, I would like to put a plug in for the mHealth Alliance, the mHealth Summit in November 2010. This is a public-private partnership with the NIH, the Foundation for NIH, the mHealth Alliance, and others to look specifically at the state of the science of mobile health, look at the intersection between research, technology, and policy across these different sectors. It's going to be a pretty big event with Ted Turner and Bill Gates keynoting the session. So please take a look at the website, www.mhealthsummit.org. And with that, these are key opportunities that we see at NIH for mobile health and wireless health that many of our institutes are actively working on. And we encourage you to talk with us as well as many of our other program officials at the different institutes about opportunities, funding opportunities, and others in wireless and mobile health. Thank you.
Thanks very much. We have time for a few questions, both from other panelists. They'll come here if there are questions, or from our NIH folks. Raise your hand, please.
I would like to ask you, who do you think should fund the early development of technology for medicine? I don't believe there is sufficient funding, and this slows down the development of the technology, which then has direct impact on not producing good enough solutions fast enough for medicine.
I think there are many different funding agencies that can. One example is at the NIH is the Gene Environment and Health Initiative, and that is looking specifically at developing different technologies, many of them wireless and mobile technologies for environmental exposures that are linked to genes, environment, and health research. And so the NIH is actively involved with that. It takes a lot of investment. It cuts across the NIH. And so it is a trans-NIH activity. The difficulty with NIH is that we have 27 different institutes, each with a specific mission. Some of them look specifically at technologies, such as National Institutes of Medical Imaging and Engineering, and the National Center for Research Resources. Others are more disease-focused, like the National Cancer Institute, National Heart, Lung, and Blood Institute, National Institutes of Child Health. And so to the degree that we can get them to work collectively in putting out funding announcements, that would benefit the whole field of mobile health and wireless health. And the mHealth interest group that we just formed in January is, to some degree, to start doing that coordination and collaboration. I think there are other agencies and organizations, such as the National Science Foundation, that we are actually actively collaborating with as well in forming partnerships, as well as the foundations like the Robert Wood Johnson Foundation and others that could play a key role in helping to develop this metal technology, as well as industry. In, again, looking at talking about partnerships, we are actively seeking partnerships with industry, NIH and industry and others, to see if we can develop some funding opportunities in this area.
Yes, so as you mentioned, the study sections are really very key, right, in making decisions on where funding is going and what are the priorities for which areas to fund. So if we'd like to promote wireless health, it gets a bit more stronger at NIH, what study section would you recommend us to volunteer to review it? So.
Well, what I would actually ask you to do is talk to your local program director at the specific institutes. They are the individuals who can nominate individuals to be on study section. You can't just say, oh, I want to be on study section, put me on. No, the process is that you have to go to the program directors, develop cozy relationships for many different reasons, not just to get on study section, but also to look at the specific policies and aspects for funding. But in your particular area, whether it be cardiovascular disease, whether it be cancer, whether it be asthma or arthritis, whatever, figure out who is the program director most friendly to mobile and wireless technology to talk with, and ask them about what different study sections there are for their specific topic area. You can go to the Center for Scientific Review website, CSR. They have a list of all study sections, as well as who's sitting on those study sections to figure out, and they have the purpose and objectives and mission for each of those study sections. For the area of health promotion and disease prevention, I can probably rattle off half a dozen study sections that a grant may go to. And then they also have special study sections as well for RFAs and others. So definitely talk with a program director, and Wendy and I are happy to point you to program directors who are quite interested in mobile and wireless technology in your particular field. Again, with our mHealth interest group that we formed, we have 20 plus of the 27 institutes represented.
Great, thanks.
Can I also add to that, your program officer is your best friend, and we want to hear from you. The worst thing we can see is a grant come in that we haven't talked to you about before it gets there. So that's your worst nightmare, and it's our worst nightmare. So remember that. We really do want to talk to you.
Let me clarify the point of previous two questions, Professor Stankovic and the previous question. So everybody in this room agrees that the golden area is really multidisciplinary research. However, culture of review panels, NIH review panels, I sit on some of them. Culture of NIH review panels is they will not support, in principle, they will not support almost anything that involves technological development, you know, even small technological development. You need clear clinical hypothesis and preferable off-the-shelf sensor that is already proven on the market. So even if you propose very minor change of software of the existing sensor, you are getting into pretty critical area that your project is going to be reviewed very bad, at least with, by some members of the review panel. On the other side, NSF will not touch anything that has patients involved. So everything is fine. We all agree that, you know, this is the golden opportunity. And, you know, we are all in this field because we are excited about this. We are passionate about this. But there is a systematic problem, and I believe that some institutions like NIBIV should really have as their mission to support multidisciplinary, but truly support multidisciplinary research. And I guess, you know, this is the reason to ask hard questions tomorrow when director of
You'll get your chance to talk
comes
to Dr. Pettigrew. But your point is well taken, that the interdisciplinary research is not just a problem for NIH, but it's also a problem for many institutions, in that they don't encourage multidisciplinary research. We have been in active discussions, many of the different institutes have been active discussions with NSF about forming joint funding opportunities, and there have been some program announcements in the past couple of years on bioengineering solutions to obesity and others that NSF has signed on to. But there are two different funding cultures. NSF is very different from NIH in not only how they fund it, but also what they fund. And so it is a continuing dialogue, a process that we will continue to look at. It is, each institute has their own particular budget and have the discretion of what they wish to fund it on. And so, again, it really depends on your particular area of health research to talk with the program directors, encourage them to go to bat for this area. Because I agree, because I'm very interested in this area, that it is a unique opportunity.
One last question.
This is actually for John in the healthcare informatics. You commented that there's a real lack of standard use of annotated healthcare data, and I was wondering if you'd consider looking, for example, at the MIT and the AHA cardiac databases as reference, because those are and have been for at least 15 years, maybe 20 years, a very standard method for testing ECG systems and arrhythmia analysis.
Right, no, that's exactly right, and we do need to learn from that. The point I was making in that we don't have the standardization is for a lot of the emerging wireless health applications that we're talking about. So if you think about some of the wireless motion capture systems that are evolving, that a lot of our groups, including my own, work on, that in those areas there isn't standardization for metadata and things like that. But we can learn from how they've done it in other areas, absolutely.
Okay, thanks.
Yeah, important question.
One more comment?
Yes, and then, about the MIT BIH database. I think the nature of this data potentially is slightly different than what is reported on MIT BIH database. EKG sensors, once you place it on the body, with the placement you're looking at basically one modality of sensor readings, whereas in motion sensing systems, depending on where you place the sensors, you're getting a totally different observations, right? So the problem resembles a vision problem. You have cameras in the system. Depending on where you place it, you get a different modality, different view of the system, and that makes it really hard to address. But definitely MIT BIH is one of the successful examples, but the nature of the problem is slightly different.